Can you tell us how you got interested in clinical psychology?
You know, I've always been interested in it. I feel like when I knew what clinical psychology was, I was in high school and we had a psychology class and I just really took to it and really was interested in it. At that point, I thought I mostly wanted to just be a clinician and, in fact, a child psychologist because I always liked working with kids. But as my career developed, I became more interested in working with adults, and even after that, became much more interested in research. I'd say at the end of my undergraduate education, and then certainly my graduate school was very research focused, and I became much more interested in the clinical research component of things.
Who were your most important influences on your career?
Definitely my first most important influence was my graduate school mentor, Rick Heimberg. I started off with a different mentor who was a child psychologist when I was going into child psychology. And like many graduate students, it was just a poor mentor-mentee match. And in fact, I would say there was a point where I thought I would probably drop out of the program and not become a psychologist. But thankfully, Dr. Heimberg took me in. I was not interested in prospectively social anxiety as something that I thought I would study in adults. Like I said, I started off wanting to be a child psychologist, but I really liked Rick. I really liked the other grad students in his lab, and a bunch of them had also switched into it, and it just became such a positive experience in terms of learning, and in terms of learning CBT and evidence-based treatments and the importance of them. So that was really an amazing experience, and like I said, I probably wouldn't have even become a psychologist at that point. Secondly, internship mentor was Dr. Michael Otto, and that was immensely helpful to my career, and he really encouraged me to break off and do my own research, which ended up being in HIV prevention, treatment, and adherence. And that also wasn't something that was going on at that internship, so it was really great of Michael to support that during internship, and that is where my career kind of took off.
And what started your interest in cognitive behavioral treatments?
Interest in cognitive behavioral treatments was really when I switched mentors in grad school and worked with Rick Heimberg. And at that point, his lab was in Albany, where also Dave Barlow's clinic was, and Rick's was the social anxiety program, but we also worked part of what at that point was called the Center for Stress and Anxiety Disorders, CSAD, that Dave Barlow was, of course, in charge of. So I had exposure to that program as well, and did the ADIS interviews, and was one of the, people that kind of helped out in both clinics, though the cognitive behavioral training that I got was doing the social anxiety groups with Rick, and that's where it basically began.
And what are your most important contributions to research and practice in clinical psychology?
My most important contributions. So when I was on internship, we developed an intervention called Life Steps, which is CBT and motivational interviewing for adherence to HIV medications. And at that point, just about 6 months to a year before, HIV medicines had a dramatic change, where before that, if you were diagnosed with HIV, you would eventually lead to AIDS, and it was a terminal illness. And around 96, I did internship in 97, antiretroviral therapy became much more potent, and much more that HIV became a chronic treatable illness. But the medicines were extremely difficult to take, had a lot of side effects, had multiple dosing times, and were really, really complicated regimens with 3 different pills that you'd have to be on, but maybe 2 of them were 8 pills, and take with food, take without food. So we developed this problem-solving intervention that would allow people to break that overwhelming task into manageable steps. And that intervention really took off. It was the first adherence intervention that was published for highly active antiretroviral therapy. There's been a number of adherence trials and interventions that were developed over the course of years, but that was really the first. And it's also become part of many other interventions to date, such as integrated into our CBT treatment for depression, because depression is highly comorbid with HIV. It's been adapted for pre-exposure prophylaxis or PrEP adherence. It's been used in many multi-site trials. In fact, it's also the standard of care adherence counseling for Doctors Without Borders, or MSF, in different townships in the Western Cape in South Africa. South Africa has the highest number of HIV cases in the entire world. And it's used, actually, I think it's part of standard of care for all of Western Cape government HIV clinics, and it's been picked up around the world. Additionally, a side interest that I ended up having while I was at Mass General on internship and then postdoc was cognitive behavioral therapy for adult ADHD, and that was just because I was so interested in just anything related to treatment and clinical psychology. We worked with the psychopharmacology unit and developed a treatment for adult ADD, and got grant funding, got first a RO3, I guess, and then an RO1, and published those trials, published the treatment manuals. One of the treatments was published in JAMA, the Journal of the American Medical Association, which is pretty tough to publish psychotherapy trials in that journal. So that's like another thing that has kind of also taken off, and that treatment's been translated to multi languages and different countries, and is disseminated and used now across the world in terms of augmenting medication treatment for adults with ADD. And from there, we also have done an adolescent version of the protocol, which is coming out pretty soon. Both that treatment and the treatment for depression and adherence in medical illness, those are published by Oxford University Press as part of the Treatment That Works series. So another important contribution that I'm really proud of is all my mentees. So from research assistants, like at Mass General and here at Miami, to graduate students, to interns and postdocs, I've had a lot of mentees that have gone off and either had careers related to HIV, but also cancer, diabetes, pain, all kinds of areas of behavioral medicine. And I still collaborate with them. I'm still in touch with many of them, or most of them. And that has been a very rewarding part of my career that I'm really proud of.
And how can we do a better job of disseminating CBT to clinicians?
I think that's one of the biggest problems in mental health in general, is that we have these treatments that are evidence-based and work for a lot of people, but are just not routinely picked up in practice. And I found that especially when I worked in Boston at Mass General, when we would have to refer people outside of our own system, where, if you just looked in the phone book or looked online and looked at people who are practitioners, they might say that they're doing CBT, but really what they're doing is like giving advice or maybe relaxation or some one or two components of things, but really not doing what like CBT experts would consider CBT. I think that's the biggest problem. What we can do better would be training frontline clinicians, such as master's level psychotherapists and social workers, who are going to go on and be the mainline frontline clinicians in community health centers, in places that are publicly accessible, and not just rich people that can afford self-pay private practice true CBT. And it's problematic because a lot of schools that want to be teaching this don't have the practicum placements, because it doesn't exist as much. They don't have a way to really place students that are in training at like CBT certified practica settings. So something needs to happen whereby the largest training institutions, and I'm talking about like master's level, are able to like really learn CBT both in the classroom setting but also on their practica as they get trained.
So what do you believe are the biggest challenges facing clinical science?
So clinical science, broadly defined in terms of clinical research that is actually applied real clinical research, and then there's also clinical science that involves basic clinical science and translational research. That's a very large spectrum of scientific contributions and inquiry. I think right now the whole clinical science and translational field gets stuck because the pieces of information which are so important and do unlock keys to what eventually becomes clinical practice are just incremental, and there's nothing we can do about it. But it's really tough because they don't necessarily always, in my opinion, make that strong of a leap to changing how a clinical intervention would look. Secondly, I think that we're really impeded. We don't know which treatments are going to work for who, and whenever studies try to do that, I feel like they end up being inconclusive. So sequencing of treatments or whether combination is going to work, there's a big gap between that and like if somebody came to me as a patient and was suffering from severe depression or severe anxiety, we really know that it's probably better to start one treatment, see how it goes, and then introduce another treatment, such as cognitive behavioral therapy and medications. But what ends up happening in clinical practice is that if they are seeing a psychiatrist and they are seeing a therapist, the person's disorder is so severe that there is a big inclination to start combination treatments, even if it's not necessarily indicated based on the research. So that's just one place, I think, where we're seeing clinical science showing one thing and we're seeing practice showing something else, and really making that gap of, first of all, I guess I'm talking about two things. First of all, the incremental nature of clinical science when it's not applied clinical research. But secondly, when findings are shown, to really translate that to practice without potentially, let's say, legal liability issues or just compassionate clinicians who really want to help. It's very tempting to start, again, like 2 treatments at once to try to get double the bang for the buck in terms of getting someone better as quickly as possible, even if that might not be what the research is showing is going to necessarily be helpful.
And what recent findings about psychopathology and mental health are likely to have the greatest impact on future research and practice?
I think sometimes, as I said, I think sometimes that is slow, but I do think that some of the newer designs of trials, which are complicated and difficult, but things like the SMART design or other kinds of studies that help determine for which people we can sequence treatments. I don't know right now if we're gonna build much better mousetraps in terms of improving cognitive behavioral interventions. I think we could move it a little bit along, but I think the kinds of things that we need are interventions that we can help, the kinds of things that we need are studies that can help determine best sequencing of treatments and also like what's going to work for who. That being said, another huge thing that we need are studies on how to disseminate and implement treatments.
And what changes would you want to see in graduate teaching and training in psychology?
Well, I think if you take psychology as a field, as I was mentioning before, a big change that I think we need is for at the master's level clinicians, master's level psychologists, really getting trained both practica and in the classroom on cognitive behavioral therapy. In terms of training, I'm involved in graduate training, and let's see, I think that sometimes it's difficult to figure out the best training concordant with all the different goals, objectives, and such that are in the APA requirements and how we interpret them. But if there were a way to streamline the APA required trainings with what I'd say a faculty and a program that wants to provide something that's a little bit unique would do in order to get the best clinicians and clinician researchers out there, I think probably it would be looking at maybe more flexible ways to meet the requirements so that students can get really good training, but do it in like 4 to 5 years instead of 6 to 7 years.
How do you see CBT evolving in the next 10 years?
I think that changes in healthcare delivery and insurance and things like that are going to very much impact how CBT evolves. CBT is one of the few psychotherapies that is short-term and evidence-based, and as different healthcare agencies, or if we ever get universal healthcare, realize that CBT works, I hope that CBT evolves in a way that it happens a lot more often for disorders and problems where it's indicated. And I think that, for example, in hospital settings, in medical settings, CBT can be extremely useful, as my research has shown, in not only treating the mental health components of a problem, but also the self-care that's involved in managing many medical illnesses. And as there are just such, I think, high healthcare costs, and many of the healthcare problems and costs associated with them could be ameliorated or at least mitigated by self-care behaviors, but self-care behaviors are interfered with through things like depression and anxiety, that healthcare agencies need to really involve CBT more in terms of providing comprehensive medical and psychiatric treatment. So I hope that we evolve in that direction to just be more prevalent and more just part of the general picture of medical and mental health care.
What areas or issues do you feel CBT needs to address more in the future?
What do we need to address more? I feel like that's kind of come out in a lot of the other questions that I've already answered, but certainly involvement in the medical system and hospital systems. There's also, I'm going to also say there's such a big push to use technology in CBT interventions, and while I do think that that can be helpful for a lot of people, I think that what we're going to find is that it's really not universally helpful. Maybe it'll be helpful for, 1/8 of the people that suffer from a mental health problem, but how much better a technology-based intervention is going to be than a self-help book, which we've had for a long time. It really involves, someone being motivated. Certainly the technology interventions with constant reminders and things like that could probably be better than a self-help book, or keeping people organized, like in the case of my work with adult ADD. But I think that learning when it actually is needed for a human to have psychotherapy with a human versus this huge push for CBTI, like internet-based CBT or computerized CBT, I think we're probably going to find that that has only a limited scope, and that we are going to need somebody to deliver treatments to people.
And how has membership in ABCT impacted your career?
ABCT membership has been fantastic. I've loved it. I have kept up with people from graduate school. I have networked with people from graduate school that then have their current faculty friends or internship friends and networked in terms of my particular research interests. I've been part of the SIGs. I've been part of the I was editor of Cognitive Behavioral Practice and part of the Publications Committee. So I've had a really strong involvement in ABCT over the years. And, it's definitely been a huge part of my professional development, my professional career. It's my professional home. And, certainly I would say in terms of networking, learning about different institutions, etc., like it's been great.